So I pass on to my.
Good afternoon, everyone. Good afternoon. My name is Jade Maina, and I work for an organization that's called TICA, Trust for Indigenous Culture and Health, based in Nairobi, Kenya. And I'm a coordinator of regional network, an Africa regional network, that's called the Mama Network. And it works to, is this better? Yes. Oh, closer is better. And it works to increase access to self-managed abortion.
Then we'll begin today's session. So it's all about challenges we'll be talking about and how we are fighting those challenges. So first we have a wonderful speaker, Mitra, who is from representing Yoni, Indonesia. So Mitra is a midwife who is passionate on advocating sexual and reproductive health and rights, especially women's and girls' rights. So let's welcome her and give this floor to Mitra.
Thank you, Regina. Today I will tell about the factor that hinder women to access abortion and post-abortion care in 3 provinces located in East Indonesia in 2023 to 2024. So this is a work together between me and Devi, my other colleague in Indonesia, and also Ika from Sansara. So my colleague in the morning and then also Ika already talked about Indonesia is an archipelagic country where we have 6 major islands, and the population now is 281 million, with the maternal mortality rate the highest in Southeast Asia. Although this is decreased than previous from 320 per 100 lives, but it's still high. And then unsafe abortion is contribute to 11% of maternal mortality death. And then in 2018, there are estimated 1.6 million abortions in Java Island, where more than 50% of them using medical abortion, also managed from and access from online. And then the incidence 43 per 1,000 women. This is based on the study from Goodmaker in 2018. So, yeah, Igna also already tell us that in Indonesia, abortion and post-abortion is very limited. We only can, the service only can be provided in hospital and with OB/GYN only. Even general practitioner cannot do the uterine evacuation both for abortion and post-abortion care. So the study objective of this is identifying the factor that hinder women to access safe abortion and post-abortion care, and with exploratory study which conducted in 3 provinces in East Indonesia with higher maternal death and highest sexual harassment case. It's conducted from December 2023, and September 2024 with total 275 informants. So this is the maps of the 3 big islands, which are South Sulawesi, East Nusa Tenggara, and Papua. So the findings safe abortion access based on the law. So Indonesia only can access abortion with medical condition and sexual harassment, sexual violence, especially rape case. And there are 4 factors that influence how hinder women to access abortion. It's criminalization, misinformation, and stigma and discrimination. And especially for the sexual violence victim or a victim, there are a double stigma because the doctor won't believe that she or her being raped. So, and even the Obstetrician Association already make a statement that they will not giving the service for sexual violence victim. But we just have the decree today, just today, at 10 p.m. that all the induced abortion only provided by OBGYN. So we can understand where they are also at the same time giving the statement that they will not provide abortion for sexual violence. That's why this all factor leads to rejection by health providers, and a single profession to delivering service is also a problem in Indonesia. So this is several two quotes from the informant. My client is a rape survivor. She rejected by the OBGYN, and the OBGYN said that she wasn't raped by her boyfriend. And also the second quote that the OB reported the client to the police because the client asking for abortion. This happened in East Nusa Tenggara. And the post-abortion access, there are several factors that we identified: that stigma, post permission, and feeling shame and fear, economic reason, relief, access to health facility. In East Indonesia is very limited. It's an island setting, so it's very hard to reach to hospital, and only one hospital in each district. So we can imagine how women with post-abortion access, they want to access, they have to go by boat, where the boat is like only one time a day, or even there's no boat at all in a day. So people said, and women also feeling shame and fear because most of people said when she experienced miscarriage, they said their uterus are weak, and they are also feeling afraid, so that they prefer to go to the traditional birth attendant before they go to the medical or hospital. And also they are stigmatized by ill-fated women. So it's a disgrace for a woman having a miscarriage. So the conclusion of these findings, that social and cultural factors are a strong barrier for women to access comprehensive sex abortion care, because even when the law is there and the derivative of law is there, and also the technical guidance is there, but the service still cannot be provided. And criminalization and misinformation is the main factor that hold a woman with medical indication and or sexual violence victim to access abortion access. And the recommendation from this study is strengthening the health system and enabling environment by addressing gender, social, cultural, and belief issues. Will support women to access to comprehensive safe abortion care in Indonesia, both in use or post-abortion. And expanding safe abortion access to primary health care is an urgent, because it is important that all women can access, especially for them who experience post-abortion care. As we know that the abortion incident is very high, so it should be post-abortion care. It should be the it should be the way out for the woman. And task sharing to mid-level provider, especially midwife, is very important to ensure the accessibility of comprehensive sex abortion care. As Igna already mentioned, that midwife is a crucial health provider where they are anywhere in Indonesia. So thank you.
Thank you so much, Mitra, for the wonderful presentation. While she was presenting, I was reflecting the scenario back home in Nepal. Even though the scenario in Nepal is like abortion is legal, but the stigma and misinformation, this information is still there. So we are also fighting for those misinformation to be destigmatized, and how we can be more vocal on how we can give access more on our reproductive justice.
Yeah, I think just to echo what Shijana is saying, and at lunch we were having this conversation and just saying, even when the laws allow, somehow the patriarchy will find a new way to introduce a new barrier. It's the same barriers we hear everywhere. So maybe also as we're thinking of the recommendations, we can also start to think, how do we destigmatize these things? How do we work on this culture or social cultural barriers? So we'll invite the next speaker.
So next speaker we have Dr. Lucy Barrow. So she's a British Academy International Fellow at the University of Birmingham and an affiliated researcher of the Global Health and Rights Project. So I would like to request her to be here and
Hi everybody, my name is Lucia. I think the people that were in room 2 already know me. But if not, we're going to be getting to know a lot of each other in these 3 days. So I am going to present today the challenges of a country that legalized abortion in 2012. So in 2012, Uruguay passed a law that allowed for abortion on demand on the first 12 weeks. And then after that, it's a grounds-based scheme with rape, incest, life of the mother, just generally like health of the mother. So I put this quote here because it's a quote of one of our survey participants. I'm going to present a study that we did together with the university in Uruguay and the Ministry of Public Health in Uruguay, trying to analyze what happened in these 10 years or more now of implementation of the abortion law. What we did was that we interviewed various key informants, key stakeholders, people that work in the civil society space, but also people that work in the provision of abortion. And I wanted to share a little bit of the results. So in Uruguay, as I was saying before, like around 9,400 abortions happen every year in the formal healthcare system, which puts us more or less at par with like countries like the Netherlands, for example, in terms of like the amount of abortions. So this is to say that abortion did not increase when the law was passed. This is one of the critiques that we sometimes hear from the opposition. So what did we find in the study? We find that Uruguay has, on paper, beautiful legal framework, very robust, very human rights based, very patient-centered. However, the reality on the ground is very different from what we wrote on our beautiful laws. Many of these laws were only written containing provisions that have to do with criminal law to protect, let's say, provisions that have to do with the dissemination of services, but many of them receive zero budget, meaning that they're empty promises to the people. So we found that one of the main barriers to access was time. None of the providers of abortion, of care, healthcare that has to be provided within the public and the private sector were complying with the times established by the law. The times are 48 hours between the request to access an abortion and the first consultation that the person had to attend. Many of them, as you can see, report that in many cases more than a week passed, which means that in many cases this pushed people outside of the very narrow 12 weeks established by the law. This is people that are being kicked out of the formal system by the formal system itself. There's a lot of complaints about interruptions and people not being able to access when they want. And I want to be very clear, unlike Mitra that was talking about a very complex island, group of islands, my country, north to south, 5 hours drive, right? This is a very small territory, easy to access, there's no geographical limitations in terms of the time that it lapses. People went to the consultation. Uruguayan law requires 5 different consultations. The first one to say that you want an abortion. The second one to get an ultrasound, it's a mandatory ultrasound, and people report these experiences. The ultrasound is obligatory according to the law. The mistreatment that people receive is not. People are forced to watch, to listen to cardiac activity, to look at the sonogram when they don't want to. They are being called, for example, oh, Lucia, come, you the one that is here for abortion, come that we're going to do the sonogram in front of a whole waiting room full of people. And our main finding out of this study is that the negative feelings that people had when accessing an abortion did not have to do with the abortion itself. Very few people reported feeling conflicted about the abortion decision. Many reported feeling anxious, sad, etc. because of the journey, because of this cumbersome process that they had to basically like jump obstacle after obstacle to be able to access an abortion. And here are like 3 examples of that, right? Like my decision was very clear, I didn't hesitate, and the process was difficult. Right? And things people like, I don't know, like, they told me you are young, you will regret it. I feel like these are things that are from Uruguay, but can apply to any of the countries that we have represented here, right? Again, terrible medical care, absolutely awful. Then here, this is a little bit connected to the title. It's like I feel singled out, a bad mother, a bad woman, and made me feel irresponsible. And I want to highlight that we received answers from all of the 19 departments of my country. We have representations also in terms of what it means to have an abortion in the capital, in a rural setting, and what it means to have an abortion with a provider, a community health provider, in more rural settings. We made a word cloud on how the words that people use to describe the abortion process. And we call it abortion process, and then we regretted it, because are these connected to the abortion, or are they connected to the process? Right? So like then we started to unpack the qualitatively with further interviews what it meant, what the abortion process means, and is the interaction with the doctors what comes out as this with these emotions. Again, no legally required, no legal requirement to show or describe ultrasound images, and these are the situations. They made me move. They made me look at the screen. They said I'm pro-life, etc. Why the consideration? We, as I said, you go to the doctor to say you want an abortion, you go back to the ultrasound, and then you go back and say, and then you have a 5-day mandatory waiting period. 5 business days, meaning technically 9 days. Because if I go on a Friday, 9 days elapse. Meaning that probably that will put me out of the legal period in which abortion is legal. So 1 in 3 considered that it was unnecessary, that they had already made the decision way before. 1 in 6 encountered conscientious objection. Uruguay, in many of the places, have more. They have 100% of objectors, so nobody's there. And the solution is that the person will have to travel to another location to get a prescription. 98% of the abortions in Uruguay are medication abortion. So the person is forced to travel just to get a prescription written, come back, pick up the medication, and go home. So there's no need for this kind of like triangulation of barriers. Yeah. So people also reported being treated differently when they went for the first abortion and when they went for the second or like more abortions. They were said that they were shamed, that they were, their sexual life was discussed, that they were told like, why are you here again, etc., etc. So very marred with like stigma, with judgment, with morality, instead of like being a site of care, it's a site of like judgment and violence. And we wanted to frame this, and I want to be very clear. We wanted to frame this also in the framework of obstetric violence. So expanding the violence that sometimes is thought to be only during childbirth of pregnancy or childbirth to the possibility of being used in its framework for abortion also, encompassing like the holistic understanding of reproductive health. That's when we colleague from South Africa talked about obstetric violence, like it really resonates with me. However, this is the landscape of access. Access is there, people are accessing abortion, but what kind of abortions are people accessing? Would I transit this? Would I recommend my sister to go through this? Would I recommend one of my friends? Probably not. This is not quality care. And in many ways, access and legality has not meant dignified quality care in Uruguay. And I think that's very clear, and I hope this is a lesson for all of us that do advocacy for legal reform. Legal reform is just the beginning. And then I wanted also to say that there are initiatives in Uruguay to try to counter this. So for example, Contá Conmigo, which is a wordplay in Spanish, would mean count with me, but also narrate your story. Is trying to kind of like, get together different stories of people for whom the abortion was an empowering experience or a sad experience, but important for their future plans, etc., etc. So really telling stories in the first person about people for whom abortion was not necessarily like the horrible journey, or maybe it was the horrible journey, but in terms of their life meant so much, such a difference. And then the phenomenon of the acompañantes, so accompagners, which is like abortion counselors that support you during medication abortion, that help you also navigate not the abortion, but the interaction with the formal system. So they're not there to support you with your pain management, with your decision or whatever. They're there to support you, to empower you in the interaction with the doctor, which is something that to me is like absolutely lovely, but it's not something that should exist at all. And then another collective, which is the one over there, that is working on obstetric violence in general in Uruguay, trying to really hold authorities accountable. Yeah, so that's it for me. You have my email.
Thank you so much, Dr. Alicia. I just remember this cold place in a hospital where I recently went for a medical checkup. And before I was analyzing how the medical bed will support my weight, because it was very unstable, I was told to quickly sit on the bed and just spread your leg. So this is what we get the treatment, even if you're educated, you're privileged, you know everything. I was thinking the scenario how it would be for a girl from a rural area, a rural community who is not able to speak, and how embarrassment that would be. So that's what our medical system is all about.
Yeah, for me, as I'm reflecting on that, I really like that we're starting to frame obstetric violence as some of these barriers that are put for women. I know most of the time when women are trying to access a safe abortion, they're already feeling shame, they're feeling desperate, therefore they are willing to accept very poor care sometimes. We don't want just access, we want good access, we want the AAA and the Q. Accessible, affordable, of good quality, you know? And also, we want happy abortions. We don't want to pass with just the bare minimum. And I think as we have these more conversations, we start to ask for more even as women.
Now we have another speaker. So she is from Bangladesh, Nujat Zahar Khan. I hope I correct. So she is a member of ASAP Bangladesh Country Advocacy Network called Youth Aid. Now she is presenting.
Hello everyone, I am Nujat Khan. I am from Bangladesh and I am also a member of ASAP's Country Advocacy Network in Bangladesh. I've been with ASAP for the last 4 years. So coming back to the presentation, to give a country context about Bangladesh, about the context of abortion in Bangladesh, it is legal under the label of menstrual regulation, which they can do within 10 to 12 weeks of the last menstrual period. But it doesn't mean that the roadway is easy. The barriers that a woman who may want to get an abortion, the barriers may come from her own family or from the service provider. In my presentation, I am talking about the family barriers. So my organization with Youth Aid, we work with young people to build their capacities on safe abortion advocacy. So while working with young people, we realized that focusing only on young people is not enough. So if we want women to get access to safe abortion, we must focus on their families as well. So, like we must include their parents too. So, yeah. So when we want to amplify the agency of bodily autonomy, so family members can become the biggest barriers. In a country like Bangladesh, we cannot just move out of the house out of 18 because if we have problems with our parents, we have to force ourselves to coexist with family, even if they are toxic or even if we don't like them. So let's get back to my presentation where I want to talk about who gets the chicken legs. So talking about chicken legs right now. So I think that chicken legs are the most delicious piece of chicken. So does anyone agree? Does everyone agree with me on that?
Yes.
Great. But a chicken only has 2 legs. And a typical Bangladeshi family, or maybe perhaps South Asian family, has 4 members. So who gets to eat the chicken's leg? Yes. Exactly. Exactly. So it is actually the person who has the highest power position in the family because of their gender, because of their financial contribution, or maybe because of their temper or loud voice. So which is, as you guessed it correctly, it is the male members of the family. And so we are looking at this in a hierarchical level. So in that case, who belongs to the lowest level in this domestic hierarchy? Guesses? Okay, so the females, especially the daughters-in-law. Right. So a piece of chicken indicates the power position of family members within the household. So in a house where women don't even have the choice to enjoy her favorite piece of chicken in a meal, how can she make decisions about her body? How can she make the decision of getting an abortion without going through the barriers, which is her own family? Sorry, I forgot to change the slides. Yes. Okay. Is this one? I'm a feminist, but there are certain popular feminist slogans that I can't relate with. One of them is "My body, my choice," because I come from I come from Bangladesh, which is a South Asian country. It's a very empowering slogan, of course, but imagine a young dependent housewife saying this to her husband who wants an abortion in a little village where the hospital or abortion service provider is 70 kilometers away. So she cannot even dare to say this to her husband or to her family members. So yeah, this is okay, next slide. Okay, so I actively work with slum communities in Dhaka. I did some interviews with young women, married and unmarried. So in the case of a married woman, since menstrual regulation is a bit easier for married women, especially if she had a child before. So when she underwent an abortion by choice, her husband supported her, but her family did not, especially her in-laws. Her in-laws did not support her. After getting an abortion, she did have to hear a lot of bad things about herself. She had to hear things like, you committed a sin by killing a child. Okay, in the second case, I interviewed an unmarried woman. She was about 19 or 20 years old, and she actually was forced to undergo the abortion. So what I heard was that she wanted to, if she had the choice, she would have continued with the pregnancy, but the abortion was imposed on her. So in a society where religion, honor plays a huge role in stopping abortion, but in her case, these could not actually help her to make her choice of continuing the pregnancy. So it all comes upon suppressing women's choices. So even honor and religion that could not help her. About youth aid. So because of our experience with young people, we thought that we should change our intervention a little bit, and target families as well. We are working with young people, but we thought that we should somehow involve the families as well through community interventions, and also somehow involve teachers as well, because comprehensive sexuality education is also very helpful. So yeah, we are working to create targeted interventions to include family members. We are working to promote community interventions so that entire families are aware of a pregnant person's choice, right to have an abortion or not to have an abortion. So, so coming to the end of the slide, so I'm comparing the choice to have a chicken leg to a woman having the bigger, having the bigger voice of choosing to have or not have an abortion, because I think that empowerment and confidence and courage, it starts at home. As soon as when the family would support a girl regarding her food choices, regarding her voices, it's only then that she will be able to speak for herself outside the home as well, and choose what she wants to do with her own body. Yeah, that's it. Thank you.
Thank you so much. Here it's chicken, but back home I think it's a milk or milk products in Nepal. Who has the right to eat that or who get the access to those nutritious food? So moving on.
We'd like to invite our next speaker. Sarah Abbas, who will be speaking to us about abortion is halal, challenging stigma through doula and community. Sarah is a community doula in training with the Adia Collective. She is based in the UK, but the collective have offerings accessible globally, and their main focus is supporting Muslims with pregnancy ending. Welcome, Sarah.
Hi everyone, nice to meet you all. Oh, sorry. Hi, I'm a bit nervous, so forgive me if I stumble a little bit. So I'm just going to kind of quickly skip through the first two slides to save some time. To just introduce my collective, we're the Edriya Collective. Edriya is a plural of dua, which means prayer. So we were founded as a response to the lack of safe, culturally competent options for Muslim abortion seekers. You know, there's a lot of stigma against abortion, but also a lot of stigma and bias against Muslims, and you know, there's a lot of judgment, even from non-Muslims, for Muslim abortion seekers, and you know, there's just so many factors that I'll be going into about this slide to, you know, kind of explain the struggles that Muslims face in this sector. So just to start off, you know, Edriya Collective, we believe abortion is ancient and sacred. It's something that we've been practicing for. So abortion is something that has been practiced for centuries and centuries. You know, there have been so many practices around the world, globally, in different cultures and communities. This is something that has existed long before the current legislations, policies and laws, and it's something that will continue to happen regardless of what decisions are made today and in the future. And you know, with regards to Islam, abortion has always been halal. You know, it's never been forbidden to have. It's always been allowed to have. You know, I'm a Shia Muslim. My scholar, you know, says that you can have, you know, IGD, an abortion up to the end of 4 months. But obviously, you can terminate your pregnancy at any point should there be a risk to anyone, to the pregnant person's life. But yeah, there's this perception that that in Islam abortion is taboo, that it's forbidden, and that's just factually untrue. Anyone who tells you otherwise is factually wrong. Any Muslim scholar that you speak to will tell you, yes, actually abortion is permissible. And yeah, in the history of like Islam, there have never been any official like bans on abortion Islamically at any point ever by any scholar, in terms of like having it legislated until like the recent, maybe last few centuries or decades even. And yeah, it's because it's something that is halal, this is Allah's will. Abortion is a sacred part of our religion. It's something that's encouraged for the comfort and safety of Muslims. So just going into some Islamic concepts, it's not specifically mentioned in the Quran, however, there are principles that support this. For example, there is no compulsion in religion, and Allah does not burden a soul beyond that it can bear. And no bearer of burdens will bear the burden of another. So that last one specifically refers to you can't force someone to continue with something that they don't wish to carry on with. And above all, the fact that natural abortive facets exist, in nature, is a sign from Allah that abortion is halal and something that is accepted and is a resource provided by Allah subhanahu wa ta'ala. So yeah, just again, there might be some differing opinions between Islamic scholars about timelines or what can be done and things like that, but at the end of the day, abortion is halal. All of them would agree on that, regardless of which Islamic scholar you speak to. And at the end of the day, the pregnant person always takes priority over the fetus throughout the whole of the pregnancy. If there's any risk to the person's health, whether it's financial, whether it's physical or emotional, and sometimes financial comes into that as well, because obviously your financial situation impacts your emotional and mental health. So yeah. Midwives or doulas have existed throughout centuries for a very long time. Our practices have existed for a very long time. In North Africa, midwives and pregnant people would ingest drinks made with boiled onions and cinnamon, for example. Whereas South Asia, midwives and pregnant people would use bark or leaves and flowers, etc., to induce abortion. So these are just examples that abortion is a natural process. It's always existed as long as humans have been alive. And yeah, in terms of the midwife or doula's role with legislation and things like that, legally in Islamic history, abortion has never really been a matter that's been brought to court. It's very rare. It's always been considered a matter between the pregnant person and their midwife. Most of the times when pregnancy-related matters are brought to court, it's when someone intentionally induces a miscarriage in someone else, and it's non-consensual. So historically, that's what's happened. So why are we where we are today? So obviously, colonialism has had a large part in the way that we see abortion, how we practice abortion, and how we access it. Criminalization of abortion and contraceptives emerged in the wake of chattel slavery's non-end. We say non-end because they say officially ended, but it still continues to this day, and the effects of it are still continuing to this day. And so from that, there's clear anti-blackness related with abortion as well. And the medicalization of historic and traditional practices, which is abortion, by medicalizing abortion, we have created legal parameters around it, meaning that there will always be someone excluded from those legal parameters, and it's unnatural. And yeah, the importation or exploitation of Christo-fascist ideologies and beliefs, such as the soul enters the fetus at conception. This is a very Christian belief, and the fact that abortion should be banned and things like that is not really something that exists around the world. It's something that was exported during colonialism and imperialism. And I wanted to just add in like the capitalist frameworks of people as workers. So how, there's obviously things, sorry, I'm losing my train of thought. Where the control of a population has always been linked to work output and being seen as workers and not as people. Let me move on quickly because I have really important points. So yeah, denial of abortion is a denial of Muslims' rights, and it's Islamophobic to have abortion bans. And you know, it's not just when it comes to legislation. There are even activists and abortion organizations that perpetuate this idea that Muslim countries are regressive and backwards because, oh, look, you know, we're becoming like these Muslim countries and having abortion bans. Like, well, actually, Islam allows abortion. I'm gonna kind of quickly skip over these because I really wanted to go into the role of doulas. I feel like that's quite important. So, Adia's answer to these issues is to expand the role of doulas in today's society. Doulas are not within any organizations or institutions. We are community specific, we are culturally sensitive, you know, and training more doulas in each community means that more people have more access to abortion information, abortion practices, and are more empowered. And they don't have to fear being reported to authorities, they don't have to fear being judged or being misunderstood by people who don't know their own local community. So that includes, for example, doulas with an understanding of disability.